वां रे महानवदाभ्यो नमः गणानाहं दवा गणपतिगं अवामहे कविं उपमस्र वस्तवां ज्येष्ठराजं ब्रह्मणस्पतये स्वाहे सन्नोदेवे तेजायिदां श्रीमन्महागणपते देवताभ्यो नमः अवैधपदस्य महाधनाभ्यो शुक्लां प्रजनां विष्णुं शशिवर्णां चतुर्भुजां प्रसन्नवदनां ध्यायेत् सर्व विघ्नोप शान्तिः प्रणम्याः ॐ मुः ॐ मुव ॐ सुव ॐ महा ॐ जनां ॐ दवा ॐ नक्यां ॐ निर्वेण्यां भर्गो देवस्य धीमहि ध्यायो नः प्रचोदयात् ॐ ॐ जय देशे अमृतं ब्रह्म पूर्वस्वरम् ॐ ॐ नमो भाक्ते तमस्रं दुर्दक्षेश्वरा श्री परमेश्वराः श्री जत्तां शुभाभ्यां शुभे श्रवणे मुहूर्तरे आद्यब्रह्मणः द्वितीयं प्रातरे श्वेत प्राहकल्पे वैवस्वताः मन्वन्तरे कलियुगे प्रथमपादे शम्भोदेवे भारतवर्षे मृदकण्डे मेरोः दक्षिणे पार्श्वे प्रहाप्ते अस्मन् वर्तमानेन विवाहरीह प्रभवादि षष्ठे संवत्सराणां मध्ये श्री विश्वासो नाम संवत्सरे उत्तरायणे मकरमासे त्रयोदशे तृतीयानां शुभनक्षत्र शुभयोग शुभहरणं एवं गण विशेषेण वसिष्ठायाम् अस्याः श्री सरस्वती देवताभ्यो नमः पूजाकालस्य सख कुटुंबानां क्षेम धैर्य वीर्य विजय आयुर् आरोग्यः ऐश्वर्याणाम् अभिवृद्ध्यर्थम् अखिलाण्डगौरिः ब्रह्माण्डनायकान्त्रे महालक्ष्मी गुडाक्ष अनुग्रहणां प्रसाद सिद्धिरस्तु अखिलाण्डगौरिः ब्रह्माण्डनायकान्त्रे धन्वन्तरि स्वामिने नमः परिपूर्णे अनुग्रहणां प्रसाद सिद्धिरस्तु अखिलाण्डगौरिः ब्रह्माण्डनायकान्त्रे सरस्वती देवताभ्यो नमः परिपूर्णे शुभकटाक्ष अनुग्रहणां प्रसाद सिद्धिरस्तु अखिलाण्डगौरिः ब्रह्माण्डनायकान्त्रे वरसिद्धिविनायक स्वामिने नमः परिपूर्णे अनुग्रहणां प्रसाद सिद्धिरस्तु अस्याः महादेवताभ्यो नमः सरस्वती पूजार्थे आरम्भः महादेवताभ्यो नमः कुसुमार्घ्यं समर्पयामि। ओम श्री महागणपते देवताभ्यो नमः। ओम नूराय मावं यरंदाय मावं कविलाय मावं गणगणहाय मावं संबोधराय मावं विघ्नाय मावं विघ्नराजाय मावं गौरवत्राय मावं गणेश्वराय मावं अंधक्राजाय मावं अव्याय मावं भूताय मावं दक्षाय मावं अदक्षाय मावं ध्वजप्रियाय मावं अग्निहत्परिधे मावं इंद्रष्टप्रियाय मावं वाणिप्रदाय मावं अव्याय मावं सरस्वतीप्रदाय मावं शरणाय मावं पदरेप्रियाय मावं सर्वात्माय मावं शशिहद्रे मावं देवाय मावं अनेहाजदाय मावं शिवाय मावं शम्भवे मावं विनाशिने मावं प्रतिशेराय मावं वामदेवाय मावं ओम ह्रीं वरसिद्धिविनायक स्वामिने नमः। नानाविध प्रवत्रपुष्पाणि समर्पयामि। अस्याः मनोमांसफल महादेवताभ्याः सिद्धिरस्तु अस्याः सरस्वती देवताभ्यो नमः महादेवताभ्यो सिद्धिरस्तु। ओम लक्ष्मीं दीर्घमूर्ते गायेनां त्रिरङ्गधामेश्वरीं दासीभूत समस्त देववनितां लोकैकदीपाङ्कुरां श्रीमन्मन्दरासितां गङ्गाधरां द्वां त्रिलोकी कुर्मयीं परदामन्ते मुहुर्तप्रियां सिद्धलक्ष्मे मोक्षलक्ष्मे जयलक्ष्मे सुरसुरे जयलक्ष्मे प्रसन्ना वरदां सुभा ओम श्री देवलक्ष्मी देवताभ्यो नमः ओम प्रभुध्याय मावाम विक्रोध्याय मावाम विद्याय मावाम सर्वदशप्रदाय मावाम स्वाध्याय मावाम सुरभ्याय मावाम प्रमाध्याय मावाम वाचय मावाम पद्माय मावाम पद्माक्षाय मावाम पद्मसुंदराय मावाम पद्मध्याय मावाम पद्मध्याय मावाम पद्मनाभप्रियाय मावाम समाय मावाम पद्ममणराय मावाम देवे मावाम पद्महिन्यै मावाम पुण्यहन्ताय मावाम प्रदन्नाय मावाम प्रदामुग्धाय मावाम प्रभवाय मावाम चंद्रवदनाय मावाम चंद्राय मावाम चंद्र सहोदरे मावाम चतुर्भुजाय मावाम इंद्राय मावाम इंद्रशेखराय मावाम आहारंजय मावाम महालक्ष्मी मावाम धनलक्ष्मी मावाम धनलक्ष्मी मावाम वीरलक्ष्मी मावाम विजयलक्ष्मी मावाम ओम ह्रीं संतलक्ष्मी देवताभ्यो नमः नानाविधं अलिवत्प्रपुष्पाणि श्रीं देवलक्ष्मी देवताभ्यो नमः नानाविधं अलिवत्प्रपुष्पाणि समर्पयामि ओम श्री महादेवताभ्यो नमः ओम सरस्वत्याय विद्महे श्रीपत्नाय धीमहि तन्नः वाणी प्रचोदयात् ओम श्री सरस्वती देवताभ्यो नमः पूजा दर्शः तत्प्रविष्टस्व ओम गां सरस्वत्याय मावां महाभद्राय मावां महामायाय मावां महावीरप्रदाय मावां वरप्रदाय मावां श्रीप्रदाय मावां वत्मनेयाय मावां पद्माक्षाय मावां स्वनुदाय मावां पुष्टः कृते मावां ज्ञानमुद्राय मावां रमाय मावां वराय मावां कामरूपणे मावां महाविद्याय मावां महाबाधः नाशिन्यै मावां महेश्वराय मावां मालिन्यै मावां महाभोगाय मावां महाभुजाय मावां महेन्द्राय मावां सरस्वत्याय मावां धर्मभोजिताय मावां कामरूपाय मावां महाविद्याय मावां मालिन्यै मावां महाभोगाय मावां महाविद्याय मावां दिव्यांगाय मावां सरस्वत्याय मावां महाकाल्याय मावां महाविद्याय मावां वेदाय मावां विमलाय मावां विश्वाय मावां विद्यामालाय मावां वैष्णव्याय मावां चंद्रिहाय मावां चंद्रवदनाय मावां चंद्रलोक विभूषिताय मावां चंद्रदाय मावां देव्याय मावां दिव्य अलंकाराय मावां भूषिताय मावां वाग्देव्याय मावां वसुदाय मावां दिव्राय मावां महाभद्राय मावां महाबालाय मावां गोखदाय मावां भारध्याय मावां वामाय मावां गोविंदाय मावां गोमध्याय मावां शिवाय मावां जटिलाय मावां विद्यावासाय मावां विराजिताय मावां चंडिकाय मावां वैष्णव्याय मावां ब्राह्म्याय मावां ब्रह्मज्ञानाय मावां सदानंदाय मावां सरध्याय मावां सदामुद्धाय मावां सुदामुद्धाय मावां सुभद्राय मावां प्रभुजिदाय मावां सुवासिन्यै मावां प्रदाय मावां विनिद्राय मावां पद्मलोचनाय मावां विद्यारूपाय मावां विशालाक्षाय मावां ब्रह्मज्ञाय मावां महाबलाय मावां त्रिमूर्त्यै मावां त्रिकायानाय मावां त्रिगुणाय मावां क्षात्ररूपिणाय मावां सुप्रदाय मावां शुभदाय मावां महावृदाय मावां सरध्याय मावां अमिहाय मावां रध्याय मावां धूम्रलोचनाय मावां मर्धाय मावां सर्वदेवस्तुताय मावां सौम्याय मावां सुरसनमस्कृताय मावां कालराध्याय मावां कलदनाय मावां रूपसौभाग्यधान्यै मावां वाग्ध्याय मावां वरदाय मावां वार्गाय मावां वार्जानसाय मावां चित्रम्याय मावां चित्रहन्ताय मावां चित्रमालिभृदाय मावां हृदाय मावां विद्यारूपाय मावां वेदाय मावां नीलभुजाय मावां सर्वज्ञप्रदाय मावां साम्राज्याय मावां रक्तमध्याय मावां निरञ्जनाय मावां निरङ्गाय मावां हंसवर्णाय मावां ब्रह्मा विष्णु शिवात्मनाय मावां ओम श्री सरस्वती देवताभ्याय मावां नानाविध रवत्रपुष्पाणि समर्पयामि ओम श्री महादेवताभ्यो नमः। ओम भूर्भुवस्वः तस्य विदुर्वरेण्यं भर्गो देवस्य धीमहि तन्नो ब्रह्म भूर्भुवस्सुधा महादेवताभ्यो प्रदानि निवेदयामि। ओम प्रणाये स्वाहा ओम नाये स्वाहा भुवनाये स्वाहा ब्राह्मणे स्वाहा आत्म आत्म अमृतया महानिवेदयामि। शुभमाग्रहयामि वनस्पते प्रदव्यां नहनां देशमुदे आग्रे सर्वरूपाणां रूपविदं निबन्धयामि। स्वनागं नक्षधानवर्तयामि आनन्देन कर्पूरः निराजनं दर्शयामि। वाम राजाधिराजाय वयसायिने नमो वयं वै ग्रहणाय उन्नहे समे कामं कामाय मध्यः कामेश्वर वै श्रवणाय धारे कुबेराय वै श्रवणाय महाराजाय नमो नमः। ओम सरस्वत्याय च विद्महे विरिञ्चिपत्न्यै च धीमहि तन्नो वाणी प्रचोदयात्। ओम श्री सरस्वती पुष्पाणि समर्पयामि आनन्देन तत्पुरः विराजनं दर्शयामि।
Good morning, respected esteemed teachers, senior colleagues, dear friends, and my fellow students. On behalf of the organizing committee, I, Dr. Anil Jackson, senior resident at the ALNC ORATION, take immense pleasure to welcome you all to the 20th ALNC Oration, being held today at Dr. K. Sanjeev Auditorium. To formally inaugurate Dr. Achinta Lakshmipathy Oration, I invite to stage today's orator, Professor Muthukumar Natarajan, our HOD, Professor M.C. Vasudevan, our Honorary Secretary, Professor Suresh Sheshadri, our Director, Dr. Punu Chandran, to stage. Thank you. We now proceed to the presidential address. It's my honor to invite Professor Suresh Sheshadri, Honorary Secretary, to deliver the presidential address. Sir, we request kindly Professor Secretary.
Of the day, Professor Muthukumar, Dr. Shivadevan, and I these are VHS, members of from 2008 to attend this oration. I feel privileged and honored to deliver the presidential address on the occasion of the 27th ALNC ORATION. This event actually holds a special place in VHS calendar every year. The one which we eagerly anticipate. Over the years, this department has organized the oration with unfailing regularity on January 30th. Its nature has grown remarkably over the years, not just due to meticulous organization, but thanks to the dozens of neurosurgeons from across the country invited to speak at every oration. Each orator has captivated the audience with their insights, and among the most memorable was Professor APJ Abdul Kalam, who was one of our nation's greatest citizens. This year's orator, Professor Rajan, is a stalwart in his own right, son of an illustrious neurosurgeon and the first student of Professor BRN, Professor Natarajan. He embodies the perfect choice for this platform. In 2023, he was awarded the prestigious BTI Gold Medal for the best paper in Association, Fine Surgeons of India. Today's oration title, drawing on Occam's razor. When the title was given, I was little intrigued. I didn't know what it was. So I tried to read up and say, what is it specifically like to speak on? It is attributed to the 14th century philosopher William of Ockham, who stated that entities should not be multiplied beyond necessity. What a profound statement he has made in the 14th century. It underscores the value of fewest assumptions to explain the evidence. This principle actually resonates across all branches of medicine, especially in surgical specialties. I recall it as a guiding luminaries like Professor K. Sanjeevi, Dr. N.S. Murali, my mentor, and Professor K.V. Trivendra. All of them followed this principle. And they used to say, do only what is necessary. If you are asking for so many things to be done before you come to a diagnosis, that means you don't know your subject. So you are not able to understand the patient well. So they emphasize this so much that I also imbibed it and applied it in my daily, in my own field of fetal medicine. And I realized how much we'll be able to save anxiety for the patient. In today's world, where we have converted, when the person goes to the doctor, there's always a huge amount of anxiety. And in my own field of fetal medicine, I find pregnancy, which is a normal philosophy, has been converted to an anxiety state. This is because some investigations are available. If I go and do this test, what will the doctor tell me? If I go this test, will something be wrong? So I think we need to move beyond that and start going back to some fundamentals. Let me take this opportunity to thank Professor Muthukumar not only for graciously accepting this prestigious oration, but also selecting a topic so timely and so essential in today's world. I'm confident, sir, that I'm confident that all of you will enjoy the oration and the interaction with Professor Muthukumar afterward. Finally, I'd like to congratulate Dr. M.C. Vasudevan and his team for keeping VHS at the forefront of neurosurgical education in our country. A special mention Dr. Anil Pandey, Dr. Rahul Srinivasan, Anil Jackson, the entire and the postgraduates who keep coming year after year, who keep the department alive, active, and ensure lots and lots of patients are benefited by providing care not only through the department at the highest level, but also truly affordable care which VHS offers these patients. And their unwavering commitment to upholding Professor BRM's values. This, I think, is very important. A person can have a vision, a person can set rules and set the path, and it is our choice to go along the path or not. But if we go along the choice, we will never fail. And that's what the department is actually doing. And once again, congratulations to the department on organizing this operation and wish you a good day. Thank you.
Thank you very much, sir, for your insightful and inspiring words. Ladies and gentlemen, an oration is defined not merely by topic, but by life, legacy, and learning of the orator himself. It's now my privilege to invite Dr. Rahul Srinivasan to introduce today's orator, Professor Natarajan Muthukumar, Head of Department of Neurosurgery at Devadas Hospital, Madurai, a revered teacher, prolific academician, guru par excellence, who has mentored over 50 neurosurgeon trainees, many of them whom to carry forward his academic torch. Sir, please, sir.
Apoplexy. It was adopted in the UK guidelines from the Society of Endocrine. And a review article on pituitary apoplexy, which was again in the monographs by the Neurology India pituitary monographs. And then he has edited Progress in Clinical Neurosciences. Now, this is an annual release from the Neurological Society of India regarding the research and latest updates in neurosurgery. And the most favorite is the practical neurosurgery, which the residents use common because this illustrates all the clinical cases and clinical scenarios useful for residents. Regarding his professional societies and leadership, he's been attached with many international and national societies. He's currently the president of Neurospinal Surgeon Association. He's a CVJ committee chair of World Federation of Neurosurgical Societies, former secretary NSI from 2017 to 2021, CMA convener from 2015 to 17, EC member from 14 to 17, former president of the Neurosurgical Academy. He's most sought after orator. So prior many orations in his name, from Dr. Rajagopal oration in 2007, and Sethi Rangachari's oration, Ramurthi's oration in IMA Tirchi, Institute Day oration at Madras Medical College, TAN's oration in April, and Professor P.S. Sharma oration at Jabalpur, March 2025. His areas of interest mainly spans around pediatric neurosurgery, mainly spinal dysraphism, also adult degenerative spine. So few of the articles which he has published is one is on congenital spinal lipoma. He has made classification simple, grouped dysraphism into very simple classification based on this embryological basis, clinical features, surgical and prognosis. So this was readily adapted by the world. And a series of publications on myelocystosils. through schematic diagrams, again differentiated between terminal myelocystocele and non-terminal. Both differs from neurologically, embryologically, as well as prognosis-wise. The same has been appreciated by then renowned pediatric neurosurgeon in the West, Professor McClone. He has congratulated on this series. And the schematic diagram which you saw in the last slide is the cover page of that particular edition of JNS, which is the most sought after journal for pediatric neurosurgery. And regarding the degenerative spine section, he has introduced new radiological science in his name. After a radiological run, is most useful for surgeons to prepare before surgery. And regarding a review article on surgical management of CSM, regarding its approaches from anterior posterior. He ends with a note that saying that surgeons should decide approach by what patient needs and not by his preference. And also a novel technique he has introduced is transversatile screws, which avoids screws and rod system which we presently use, which is simple, cost effective and biomechanically smooth. Lot of awards and recognition, but as Professor Suresh also mentioned, P.T. Ingalekar Award from the ASI Group at Australia is a sought after faculty for operating neurosurgical workshop at the Park Clinic and AIMS, New Delhi. Is a reviewer for major national and international journal, also invited speaker at multiple state, national and international meetings. A slide regarding his father. His father is also a neurosurgeon. He started the Department of Neurosurgery in Madurai Medical College. He was first few trainees under BRM, and you can see this. This was inaugurated on 9th September 1963. The department was inaugurated. A few features regarding his father is he was the lone neurosurgeon available in the south of Tamil Nadu that particular time, and he also served both as neurosurgeon as well as neurologist until 1971. And he started a head injury unit in 1982. And celebration of 20th anniversary, you can see this picture. BR was the chief guest that particular time. And 1986 he retired but continued to teach students till 1990. Now this is the list of head of department at Madurai Medical College. You can see the father and son, both names are there at different tenures. And this show depicts the generational dedication to the subject. What is unique, though he had a natural inspiration from his father, he is unique, totally unique, because he can easily identify a core problem, give effective solution, simpler solution, encourage reciprocal learning, and knowledge he disseminates through his seminars and teaching through various publications. Now you can see the slide which I show is a routine template what he uses, a dark ink slide with fonts of red and white and yellow. And you can see a few camera clicks which I had during my residency when I attended his conference in life. So I once again welcome Professor Natarajan Muthukumar. I invite now Dr. M.C. Vasudevan to provide the orator medal and then followed by oration. Thank you.
Thank you, Rahul sir, for that elegant introduction. The moment we all have been eagerly waiting, it is my proud privilege to invite Professor Muthukumar Natarajan to deliver the 28th ALNC oration. Sir, the stage is yours.
Thank you. Before I begin, I think I should first of all thank Rahul because of Rahul's strategy. So today I learned from you how to introduce an orator. It's never, one is never too old to learn from somebody. Today I learned from you how to introduce an orator because you just didn't read from the CV I sent. You had done some research. If you stop that thing, right in the later. Good morning. The outside, it's my pleasant duty to thank VHS and the Acharya Lakshmi Research Center for the last day and the Granny Party and the entire team and VHS for bestowing this honor on me. It is indeed a pleasure, privilege, and honor to deliver this prestigious Acharya Lakshmi oration. The first time I came to know about Dr. Acharya Lakshmi was in July 1983. July 1983 was the month when I joined MCS Neurosurgery. As I walked into the portals of Madras Institute of Neurology to report to the director, and the first thing I saw as I entered on the building was on the left side was a bust-sized statue of Dr. Ashwini embedded in the wall. So I went through that entrance for 5 years continuously. Almost we were on duty 24/7, 365 days in Madras Institute of Neurology under the benign gaze of Dr. Lakshmi. Subsequently, I came to know about Dr. Lakshmi's contribution, Dr. Rukmini Lakshmi, and their relationship to Dr. Ramurthy and Dr. Indra Ramurthy, both of whom were very close family friends. And thanks to this, the generosity of Dr. Lakshmi and his family, the institute where I think they made a substantial financial contribution to this particular institute. Thanks to that, several generations of scores of neurosurgeons and neurologists in Tamil Nadu owe their training and existence to this great gentleman and his family. And last year, when this building which was established by Dr. Ramurthy, was demolished to give way to the new building, I called up when that was posted in the WhatsApp group, I called up the incumbent director of Institute of Neurosurgery, Dr. Raghavendran, and told him that this statue should be preserved for posterity and it should get a new place in the new institute. And Dr. Raghavendran is a person who knows history and tradition. He said that he's done that. He has ensured that statue will be preserved and placed appropriately in the new block. And that is a simple token of gratitude to this great man whose vision and philanthropy has made us what we are today. My relationship with Dr. Ramurthy goes back to my childhood. My father was the second student of Dr. Ramurthy. At those days, I believe, from what my father told, the Madras University, it was not as MCS University, but as MS University. Madras University did not even have a curriculum because at that time there was not even a textbook for neurosurgery. And this photograph was taken when I was in, I think, first or second year MBBS. And those in VHS, especially at the last time, might know that every May, Dr. Ramurthy used to spend his time in his residence in Kodaikanal. So on the way to Kodaikanal and return journey, he will have breakfast in our house, and my father used to drop him. On this particular day, I at that time only I got the license, and I asked my father to let me drop Dr. Ramurthy in the airport. My father did not want to trust his guru's life with his son. So he said no, but Ramurthy, he said, Dr. Natarajan, let this young man try. So I dropped him in the airport. 20 years later, I get a letter from Dr. Ramurthy, and he was revising the second edition of Ramurthy's textbook, Ramurthy and Tandak's textbook of neurosurgery. He had asked me to write 2 chapters, embryology of the spinal cord of the brain and embryology of the spine and the cranium, 2 tough chapters. And it took nearly 2 months for me to read up and prepare those chapters, and I sent it. 1 month later, I didn't get a letter. My father got a letter from Ramurthy praising my academic work. And what he mentioned was really something we should learn. He had written a letter not to me but to my father, and he had written that you have raised him well. You have raised him well. That is the best compliment any parent can get. And this is the second oration which Dr. Ramurthy has established, which I am delivering. The first oration I delivered was in December 2017. Oration established in Trichy IMA. Trichy IMA was one of the founding members of Trichy IMA was Dr. Balasubramanian, the father of Dr. Ramurthy. And Dr. Ramurthy established an oration in his own name at Trichy IMA, and I had the privilege of delivering that oration in the year 2017. Now, having done with the preliminaries, let us go to the topic, Occam's razor in neurosurgery. And Dr. Suresh has very rightly pointed out what Occam's razor is. Occam's razor is something named after a Franciscan priest known as William of Occam. Occam is a small village in the county of Surrey in southeast England, and it is famous only for this razor. It is also known as law of parsimony or doctrine of simplicity. What does it actually mean? It means the simplest theory that makes the fewest assumption should be accepted. Just because something is complex, that doesn't mean that is the correct thing. And the word razor is used as a metaphor, as a figure of speech for shaving away unnecessary complexities. So favoring conciseness. In medicine we have been traditionally taught to attribute patient's symptoms and signs to one diagnosis. That is what I was taught during my undergraduate period, during my postgraduate training. And multiplicity of diagnosis is generally not encouraged. I still believe that is a correct way to do it. But Sir William Wasler is widely believed to be responsible for introducing this particular principle in medicine. I remember having read it in New England Journal of Medicine long time back. I could not get this source. And we have traditionally therefore attributed one etiology for one disease. This has resulted in the unified hypothesis for many diseases like Chiari and Series, because we prefer, as humans, we prefer simple explanations over complex ones. There are certain problems with Occam's razor. One is we assume to the truth because simple is not always equal to truth. Second is oversimplification. We tend to reduce complex phenomena that leads to reductionism. Now, what about Occam's razor in the context of Chiari and Series? Chiari 1 malformation. it's not correct to call it as a malformation because unlike cherry 2, 3, and 4, 2, 3, and 4, which are malformations in the traditional sense of the word, cherry 1 is many times an acquired anomaly. And it is widely believed to be due to developmentally small posterior fossa with results in cherry. And 2014, Atul Goyal had attributed cherry to Atlantic axis dislocation. As far as syrinx is concerned, all of us know the various theories that exist, including Gardner's water hammer theory, Williams differential pressure theory, etc. The most recent one is Oldfield's unified hypothesis. My question is, are the above theories true? There are two recommended treatment modalities for cherry. One is the foramen decompression with or without neuroplasty. Second is a little more controversial C1C2 fixation. Are these the only ways to treat all patients with cherry? Now, the aim of this presentation is to highlight that cherry 1 is a disease with multivarious etiology. We as neurosurgeons have been taught there's a primary cherry and there's a secondary cherry, a pseudo cherry. The aim of this presentation is to show that tonsillar herniation or cherry 1 is just a radiological sign. It can be due to multiple diseases. And I will explain this using clinical examples taken from my own practice. A couple of examples I have taken from the literature. Where I have taken from the literature, I have given the appropriate references. Now, that brings us to the question, why should we discuss this topic at all? This massive meta-analysis of 8,600 patients show that only 74% of patients with cherry improve. 9% actually deteriorate. Complication rate is as high as 43%. Please remember this 43% includes even minor complications. And for a benign condition like cherry, the mortality rate is 11%. Right? Now, what about redo surgery for cherry malformation? Once again, there's a high incidence of failure. Even if you do redo, a substantial portion of patients will fail surgery. That means you have not properly understood the pathophysiology of this disease. To understand the pathophysiology of this disease, we need to understand why this disease is caused. Disease can be due to decreased intracranial volume or increased pressure. The decreased volume can be due to a developmentally small posterior fossa, which is traditionally constructed in the cast, or it can be due to craniovertebral junction anomalies, which compromise the ventral brainstem, or it can be due to increased pressure, which can be due to CSF circulation disturbances and venous hypertension. I'll show you some examples and highlight this problem. Now, this is the classical textbook description of cherry malformation. Most 70% of the malformations will fall under this entity. For example, this 18-year-old nursing student came to us with neck pain, clumsiness of hand, impaired sensations, and no several signs. And this is the T1, T2, the images which show the syrinx and the tonsils herniating right up to C2. What we did was a classical foramen decompression, intradural exploration. We coagulated the tonsils and then do a liberal neuroplasty. Of course, the patients improved. See the pre-op and post-op, the tonsils have ascended and the syrinx has completely disappeared. This is a classical textbook description. Most of the cherries do fall under this entity. The next is craniovertebral junction anomaly causing ventral brainstem compression. For example, this 23-year-old female MSc computer science graduate came with us with gait difficulty, pyramidal and cerebral sign. And this is the MRI, which shows a tonsillar herniation, a syrinx, and ventral brainstem compression. And this is a CT, which shows a severe platyphasia. And there are two components to the glibus, the basi sphenoid and the basi occiput. Look at the basi occiput. The basi occiput is very much shortened, foreshortened, and there is also a retroflex odontoid. Now, this what we did for this patient is put the patient under traction, expose the C1C2 joint, place the spacers inside the joint to pull the odontoid out of the foramen magnum, did the C1C2 fixation, and then we did a bony decompression of the foramen magnum. We didn't do an intradural exploration. These are the post-op images which show the descent of the odontoid and the FMD, foramen magnum decompression. These are the post-op images which show the implants in situ and the spacers in situ. That's the 1 month pre-op. There's a pre-op and 1 month post-op which shows complete disappearance of the syrinx. And you look at the ventral subarachnoid space anterior to the brainstem. It has opened up, which shows the brainstem has been decompressed. And the tonsils have also ascended. Now we need to understand how a craniovertebral junction anomaly can cause cherry. To understand that, we have to understand there are three pathologies in this particular entity. One is that horizontally oriented clivus with a short basic occiput. Second is Chiari. Third is retroflex oriented. Now, the problem is the basic pathology is number one. The other two are the consequences of the first pathology. Now, how to explain that, we have to look at this beautiful publication by Pang and Thompson. The upper image shows the normal lie of when the clivus is normal, this is the normal plane of the foramen magnum, and this is the normal volume of the posterior fossa. When the clivus is platypus or horizontally oriented, or it is very short, now the plane of the foramen magnum is elevated. That decreases the volume of the posterior fossa and brings down the tonsils. That explains the chair innervation. How do you explain the retroflex orientoid? Once again, go back to the same publication. The dotted lines indicate the normal anatomy, and these routine lines indicate the abnormal anatomy. Now, this is the normal lie of the clivus. When the clivus is normal, this is the normal lie of normal angle of the occipital condyle. Whereas when the clivus is platypus, what happens is, because the plane of the foramen magnum goes up, the occipital condyle also gets tilted. Because there's a lordotic tilt of the occipital condyle, the developing odontoid becomes retroflex. That explains. This is how the pathophysiology changes. So we should not simply do FMD for every patient. And I strongly believe, which some of my colleagues might disagree, we should not simply do CNC fixation for every patient. Now, let us see some literature. This is 101 patients with Chiari. 20% of them had required occipitocervical fusion. And the risk factors were, once again, basilar invagination, platybasia, and Chiari 1.5, which means the bovex is below the foramen magnum. This is from a leading pediatric neurosurgical center in Salt Lake City, Utah, famous pediatric neurosurgeon by name Douglas Brockmeyer. On this particular publication showed that the greater the odontoid is angled posteriorly, the greater is the degree of the displacement of the tonsil and the opex. Now, what about the incidence of bony anomalies in children, in patients with Chiari malformation? This is anal medicine who passed away recently, is one of the world authorities on craniovertebral junction. In this series, there's a 33% incidence of basilar imagination in patients with Chiari. Whereas another big series from Atul Goyal from Bombay, he has among the 388 patients, the incidence are 47.6%. I believe these two numbers are on the high, not because I'm not saying that the numbers are false, because both of them are well known for their work in craniovertebral junction. So it's very likely there's a skewed referral pattern where complex cases get referred to these expert surgeons. For an average neurosurgeon in India, in the Indian subcontinent, I believe the incidence of bony anomalies will be somewhere around 20%. Incidence of bony anomalies, if you take 100 patients with Chiari, incidence of bony anomalies somewhere around 20%. That's a realistic percentage. Now we come to the next pathology, increased pressure. Now, CSF circulation disturbance can also cause both Chiari as well as Graves. Now, let us look at this 13-year-old male, the son of our hospital pharmacist in Mother Medical College. At the age of 2 months, he underwent a VP shunt for congenital hydrocephalus, lost for follow-up. At the age of 12 years, the boy presented to me with fundus. CT was showed arrested hydrocephalus. I decided not to do anything. 1 year later, this boy comes with headache, fundus was normal, and had associated neck pain. And this is what the scan shows. Now, the white arrow, that's a pan-ventriculomegaly, as all of you can see. All the 4 ventricles are dilated. The white arrow shows the Chiari, and the yellow arrow shows what is known as the pre-serine state. It's a condition that occurs before a full-fledged syringomelia develops. And you can see the communication between the fourth ventricle and the syrinx. Now, for this patient, this is what is known as hydrocephalic hydromelia. This term is not very commonly used because most people do not understand the relationship between hydrocephalus and the hydromelia. And the beautiful article by a Japanese pediatric neurosurgeon, which appeared long time back, but I think anybody who sees a patient with hydrocephalus and syringomelia should read this article. For this particular patient, we just did an ATV. Nothing, we didn't disturb the shunt. We just did an ATV and we solved the tonsillar ectopia and the syrinx. This is 2 months. This is 18 months. Notice the complete ascent of the tonsil, complete regression of the syrinx, open sulcal spaces indicating decompression. So in the 4 or 5 months ago, I think somewhere in September, I got this AGS follow-up for this boy who is now doing very well. He's now a medical student in Pondicherry. Now, there is another patient who presented us somewhere 20 years ago, a young girl, known case of arrested hydrocephalus, decompensated and presented with pre-syringe state. For this patient, we did BP shunt, and the patient improved and was accepted without any alteration in Journal of Neuroscience Pediatrics in 2005. Now, is there an entity known as communicating ceremonia? Because last time when I presented somebody asked me a question whether an entity known as communicating ceremonia, because most people have not read the fantastic work of Thomas Mulherath. Thomas Mulherath has classified ceremonia and communicating, non-communicating, and extracavitary, right? And time does not permit me to go into the pathophysiology of communicating ceremonia, etc. But it's important that the junior members of the audience, the neuroscience, should read this particular article or all the publications of Thomas Mulherath. Now, this case scenario 4 is a 33-year-old female who presented with the classical textbook description of syringomyelia, hand muscle wasting, half-cape sensory loss, and trophic ulcers. And this is the MRI which showed a panventriculomegaly, a GRE1, holocaust and evidence of communication of the fourth ventricle with the central canal. And for this patient, we just did a medium pressure shunt on the right side. Post-op CT revealed the decompressed lateral ventricle, but a persistent dilatation of the fourth ventricle, as you can see here. So what we planned a post-coronary decompression with intradural exploration along with upper cervical laminectomy with the proposal to do a cerebropleural shunt. Now, once we open the foramen of vagina, not only the caesar gushed out, not only the fourth ventricle collapsed, but the cervical cord also collapsed. Therefore, the planned cerebropleural shunt was done. Now, how this happened? This patient, of course, improved, and follow-up MRI, as shown here, showed regression of both the scary and the syrinx. Now, to understand this pathology, the left side is a panventriculomegaly, routine panventriculomegaly. The image shows as though the central canal is in communication, but central canal is only a potential space. So this is only a potential space. It does not normally contain CSR, and all the four ventricles are dilated. Now, what has happened is that on the right side is what this patient has. This is known as holoneural canal dilatation. This is a term used by Sishu OE, which is the reference I showed earlier. Now, what has happened for this particular patient is, this is a condition after we shunted, the third and lateral ventricles collapse, the fourth ventricle and the syrinx remain open. That is a condition known as isolated Roman-cephalic. And this is the article which I referred to. It's a beautiful article. Anybody who has a patient with hydrocephalus with syringomyelia should definitely go through this article. It's a wealth of information. Unfortunately, this article is not very highly cited in the literature. Now, let's come to case scenario 5. This is a 14-year-old male. At the age of two years, this patient underwent a shunt for postmeningeal hydrocephalus. And in 2007, he came to us for a revision, at which time he had a panventriculomegaly. In 2010, he presented once again with shunt dysfunction. At this time, the CT showed disproportionate dilatation of the fourth ventricle. This is the shunt during the first scan at the time of first dysfunction, where all the four ventricles are equally dilated. This is a shunt in 2010. Notice the disproportionate dilatation of the fourth ventricle. By this time, I had understood the relationship between hydrocephalus and syrinx. Therefore, I got an MRI done. I thought I'll get the same result like the previous case which I referred to. There's dilatation of all the four ventricles, and there's communication with this central canal. What we did was we just did a shunt, and I was pretty sure I'm going to end up with an isolated Roman-cephalic ventricle like the previous case. But nature always befuddles you, and this patient absolutely became normal. Look at the photograph scan. There's complete regression of the CRE and the series. Nothing was done. Just revise the shunt. And this is something which we were published as soon as we sent it for publication to ACT, which got accepted without any alteration. And this is the role of how syringomyelia can be a presenting picture of sun dysfunction and the implication of pathogenesis, which we published in 2012 in Journal of Cranial Junction and Spine. And now we come to venous hypertension. Venous hypertension is very common in craniosynostosis, especially syndromic craniosynostosis, where multiple sutures are involved. The incidence is very high, and it is due to decreased volume and increased venous pressure. This is a reference which I taken from the literature. And last week I was in Rishikesh for a Indian Society of Pediatric Neurosurgery meeting, where this beautiful paper was published from Niemann's, was presented from Niemann's. They studied incidence of CRE in pan-suture synostosis. Last Friday, this paper was presented in Rishikesh. They found an incidence of 70% of patients with pan-suture synostosis have CRE malformation. This is Indian statistics, not overseas statistics. My interest in craniosynostosis and CRE was stimulated by this particular young boy who was referred as a case of CRE and syringe, and I found it to have a dolichocephalic head. And this is the MRI which showed syringe and cherry. So at this time, I took a deep dive in the literature to find out. Actually, this publication says that if you take monosuture synostosis, 5% of patients can have cherry at the preoperative MR. It is due to the abnormal development of the lambdoid and coronal suture, leading to inferior migration of the tentorium and tarcal. This is a publication which says that 27 among the 174 children with cherry, 27% had sagittal stenosis. The last line is the most important. Among the patients with sagittal stenosis, isolated sagittal stenosis, 15% can have symptomatic cherry. And this, my patient, which I referred to earlier, comes under this particular 15%. So one case, on many occasions, one case has stimulated me to go into the literature, and that has led to a collection of large number of cases, which in turn was presented in many meetings, which was subsequently published. So even if it's a single case, we should not just, for the younger members or a single case, just start reading about it, document everything, and one day you can make it into a beautiful presentation or a publication, which will be there for posterity. And for this patient, you need not do any permanent magnetic decompression control. All you have to do is treat the cranial stenosis, increase the cranial volume by whichever way you want. You want a cranial vault remodeling, you want a cranial posterior vault expansion, or you just do a distraction osteogenesis, as this particular case shows. They have not done anything to they have not fixed the C1C2, they have not done a permanent magnetic decompression, they have just done a distraction osteogenesis. Look at the pre-op, 3 months post-op, 9 months post-op. The cherry decreases, the syringe also decreases. Now, this is a very interesting topic. I too became interested in this particular condition because I saw 2 patients with idiopathic intracranial hypertension who were treated in some of the best centers with very knowledgeable neurosurgeons, undergoing FMD and deteriorating very badly. So I took a literature search, and I found this beautiful article in American Journal of Neuroradiology, where 43 patients with confirmed idiopathic interconnection and 45 patients with age-matched controls were screened for cherry1, and they found 20% of patients will have tonsillar displacement. And this is a case report in this particular publication, where a 43-year-old lady was diagnosed to have a cherry1 under syringe, and somebody did the FMD, as all of us will do. Probably we would have also done several such cases. And the patients presented with headache, the headache did not improve. Patient developed actually worsening of headache, and patient developed pseudomeningitis. After several weeks, somebody decided, as Dr. Suresh rightly pointed out, somebody decided to look at the fundus, which is a forgotten art nowadays. As I visited the Dr. Ramamurthy Neuroscience museum, I saw several ophthalmoscopes there. So the present generation must also look at that. So somebody decided to look at the fundus, they found a papilledema, and they did a revision, and the patient symptoms improved. Now let's look at what are the literature say. Literature says among patients with idiopathic internal hypertension, nearly quarter of them will have tonsillar ectopia. It is very likely that many of these patients are, because patients with cherry can also have headache, can also produce the headache. Only things, the nature of headache might be a little different, but sometimes it can be misleading. So when a patient comes to us with tonsillar ectopia plus minus syringe and headache, it is before we just rush in to do FMD, we have to look at the fundus. The PubMed search revealed 87 references with the above combination, with cross references the number exceeds 100. Now I am going to focus on this publication here. A 66 patient with cherry were compared with 41 with the idiopathic intracranial hypertension. And what the authors found was ICP monitoring showed raised ICP in both the groups. Intracranial volume was contrary to the expectation. The posterior volume did not decrease in the group with subgroup, which means they did not mention anything about the pathogenesis. I have a feeling probably there is a relationship between some patients, at least with the so-called cherry, may have an idiopathic intracranial hypertension, which probably we should exclude before we rush into doing it. Now, if we think increased intracranial pressure is the only thing that can cause tonsillar inhalation, think again. This particular condition, spontaneous intracranial hypertension, can also lead to cherry. This is taken from this particular publication, Journal of Neurosurgery, where the preoperative image showed a tonsillar herniation, and somebody went ahead and did a FMD. Obviously, patient's headache worsened, and the cherry, as you can see, worsened, if you can look at the optic chiasm, which is flattened, and if you look at the second image, worsening can be seen. Not only the tonsils have herniated further, the distance between the mammary body and the upper portion of the pons is decreased, which means the spontaneous intracranial hypertension has worsened. So after that, once again, like the previous index case, somebody decided to do a CT myelo and found a leak in the spinal theca. All this patient required was a focal epidural spine patch that would have resolved this particular patient's problem, whereas the patient ended up having an unnecessary surgery. So spontaneous intracranial hypertension can present with sharing. And the literature shows about 73 references, the overall incidence is 20% of patients with spontaneous intracranial hypertension have sharing. Now, this is obesity and sharing. This is something which I came across only a few weeks ago when I was preparing for this particular lecture. And it's interesting to know that the 167 patients with Chiari, 40% had obesity. And they divided the patients with less than 10 age and more than 10 age. They found patients with Chiari less than 10 years of age, there's a high incidence of obesity. We also know obesity has a relationship to idiopathic intracranial hypertension. So therefore, this authors postulated whether weight loss should be a treatment option. Just a postulation. This is something we have to obesity, idiopathic intracranial hypertension, and Chiari. Probably whether they are all related, something we have to contemplate. I am not for a moment suggesting that patient with Chiari you have to go for weight loss treatment. I'm just suggesting that you have not understood the pathophysiology and the relationship between these diseases. Sometimes nature itself cues the disease. This is a young lady who came to me in 2009. The left two panels show the images from 2009. The right two panels show the images from 2012. When 2009, she came to me with the portions of voice. I got an MRI done. She had a Chiari and a syringe. Right to all of us, I also suggested surgery. This lady, for some reason, refused to undergo surgery. She was lost for follow-up. 3 years later, in 2012, she comes back to me and she says that her Houston voice has improved. I convinced her to get an MRI done, and there was a resolution of both the Chiari and the syrinx. Spontaneous resolution of Chiari is known to occur in children because as the child grows, the head volume increases, and that is supposed to lead to resolution of the Chiari, but it has not been reported in the literature. So therefore, when we send it for publication, once again, without any alteration, it's accepted immediately. Please don't ask me how this happened. I also don't know how this spontaneous resolution happened. I don't have an explanation for that. As doctors, as surgeons, as neurosurgeons, we want everything to be in black and white. We want an answer for everything. What this tells us, and many of the examples I have told you earlier, life, neurosurgery as in life is not in black and white. It is in black and white. There are different shades of gray. We have to accept we do not know certain things. Now, this is the last thing. Can abnormal course of the pica cause syrinx? Because I saw one of my colleagues in a webinar presenting about syrinx, and he showed a few examples where the pica was found inside the foramen magnum. So I went back and did a little research. And this and Arnold Menezes, as I referred earlier, one of the world authorities in CV Junction. Yes, they did a study on intradural pathologies in Chiari. They found medial-aged tonsils in 100%, intertonsil or arachnoid adhesion in 85%. And interestingly, 43% of patients had the artery lying within the foramen magnum. And the incidence of syrinx was higher in patients where the pica, tonsillar segment of the pica was lying within the foramen magnum, even though that was not found to be statistically significant. They did not suggest that this was the reason for, please understand, they did not suggest that this is the reason for syringomyelia. They just mentioned this fact because, like true scientists, they have made an observation. The observation cannot lead to conclusion because any of the three things, either the medialized tonsils or the arachnoid adhesion or the pica, anything alone or in combination can cause syrinx. So they just left it like that. And this is the image that is taken from that article. On the left image, you see the pica in the region of the foramen magnum. On the right image is the intraoptic photograph, which shows the tonsillar segment lying within the foramen magnum. Now, conclusion. My conclusion is that over a period of time, my understanding of Chiari and syrinx has undergone a sea change. I now strongly believe Chiari is not a single disease entity which can be treated by a single standardized surgical approach. I know this is going to raise the hackles of many neurological numbers in the audience, but my idea of this presentation is to provoke a discussion, provoke a thought process which goes against the established status quo. I believe now chair is just a radiological sign which can be caused by several different disease processes. The etiology may vary. Therefore, we have to identify the cause and treat it rather than just directly treat the effect. We should not treat the effect or the symptom of the disease is charing. Therefore, I made this suggestion which some people might do not accept. All share is a secondary. Identify the cause and treat it. The reason why we have a very high failure rate, which I referred to earlier, is because we are we are misdiagnosing several diseases as just a simple Chiari incidence. Therefore, a one-size-fits-all treatment modality should not be applied to patients with Chiari. A clear understanding of the pathophysiology is required for optimal treatment and good results. Now, this is a chart which I found in one of the podcasts. Every day there's a beautiful podcast by a person known as Alok Jain, and he presents the stock market data in beautiful scientific way. Some of which is above our head, but this is the x-axis is the knowledge in the field, y-axis is the confidence. I was in this, I know everything soon after my MCS training. I went through this graph after now. I finished my MCH in 1988, so almost more than 3 decades in the field. Now I'm somewhere that, trust me, it is complicated. Now let's come to Occam's razor. The greatest obstacle to discovery, according to American historian known as Daniel Boorstin, is that it's not ignorance, but it's the illusion of knowledge. And this is a famous statement by Mark Twain, which most of you might know. It is not what you don't know that hurts you. It is what you know that isn't so. Now that brings us to two other entities. The opposite of Occam's razor is Hickham's dictum, which says a patient can have as many diseases as he can the diseases. And the Crabtree bludgeon, which says it's especially true for medical professionals because we tend to have a preconceived hypothesis and try to fit our data to fit that preconceived hypothesis. That is classical. You bludgeon the data. You bludgeon the data to fit a preconceived hypothesis. Now, Hickam dictum reminds us to consider multiple causes. Crabtree bludgeon warns us against a single cause bias that tends to fit everything into one diagnosis. What we have been doing, according to me, all along in Chiari settings, is nothing but Crabtree bludgeon to fit our pre-existing but erroneous understanding of the disease. We have postulated a hypothesis and we are trying to fit whatever is seen into that hypothesis. I don't know how many of you would have read the Da Vinci Code by Dan Brown, and that in Dan Brown, the villain will say to Robert Langton, who is the Harvard professor of symbology, at one point of time, referring to the Last Supper drawn by Da Vinci, the mind sees only what it chooses to see. Mind will see only what it chooses to see. If you have already made up mind, if the radiologist, because nowadays patients do not come to us directly, already somebody has done an MRI, patient is referred as a case of Chiari ulcerations. You see it in OPD, when can I post the patient for FMD? I mean, all of us have done it, including yours probably. I have also done it. So it is time we take a step back and find out whether what we are doing is right. So Occam's razor is a good heuristic for a mental model. It certainly makes decision easier by reducing the cognitive load. I am not for a moment suggesting that Occam's razor is not good, but no principle in life or no scientific law can be 100% perfect. God has given us gray matter to think and analyze whether this is true. Therefore, we have under Occam's razor is just a heuristic model. It is not a rule or a law. Indiscriminate use of anything, even if it is good, can be risky. So therefore, conflating simple with correct is dangerous. It can lead to erroneous conclusion. In medicine, erroneous conclusions lead to erroneous treatments, which in turn harms the patient. Thank you for your kind attention.
Thank you, sir, for a truly enlightening and thoughtful provocating oration. We are richer for having listened to you today. On behalf of the organizing committee, it is my proud privilege to propose a vote of thanks for this August gathering, the 28th ALNC oration. First and foremost, we express our deepest gratitude to our distinguished orator, Professor Natarajan Muthukumar, for taking time out of his busy schedule for delivering a truly inspiring and insightful oration. Sir, your lifelong commitment to neurosurgery, academics, and mentorship continues to guide and motivate generations of neurosurgeons. We are deeply honored by your presence and your words today. We extend our sincere thanks to our Honorary Secretary, Professor Suresh Sheshadri, for graciously presenting the Presidential Address, which beautifully set the tone for this academic session. We also thank the Director, Dr. Purnachandran, and our CFO, Mr. Suresh Sheshadri, for their support. We thank our Head of Department, Dr. M.C. Vasayan, for presenting the Oration Medal and being a part of this moment to honor and recognition. Our heartfelt appreciation to Dr. Rahul Srinivasan for the elegant and thoughtful introduction of the orator, highlighting a remarkable academic journey and legacy of Professor Natarajan Muthukumar. I also thank all the doctors and professors from IIT for their presence here in their busy schedule. We sincerely thank the organizing committee, faculty members, all the ALNC office staffs, and administrative staffs who work behind the scenes to ensure the smooth conduct of this program. We also thank all the delegates and participants for their presence, enthusiasm, and active participation, which truly made this oration meaningful. Finally, we acknowledge with gratitude the support staffs, our IT department, volunteers whose efforts contributed greatly to the success of today's event. With this, I once again thank everyone for being part of the 28th ALNC oration and invite you all to join us for lunch and also visit our Professor B.R. Ramurthy Museum, which is adjacent to the dining area on the second floor of Ramurthy Block. Thank you. You can stand up for national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
I request ALNC staffs and orators to come for the photograph, sir, an annual photograph. Please come, sir.